Welcome back to Revenue RX, the podcast at the intersection of pharmacy and finance. I'm your host, Lubna Mazen. We spent the last few weeks talking about NDCs, HCPCS codes, revenue codes, and modifiers. Each one plays a different role in getting a drug from the pharmacy shelf to a paid claim. Today, we're talking about what connects two of those pieces together. That is the NDC-HCPCS Crosswalk. Think of the NDC-HCPCS Crosswalk as the Rosetta Stone of pharmacy billing. The original Rosetta Stone was discovered in Egypt in 1799. It contained the same message written in 3 different scripts. Since scholars could already read Greek, they were able to finally decode Egyptian hieroglyphics. The Rosetta Stone didn't create a new language, it translated between languages that already existed. The NDC-HCPCS Crosswalk serves the same purpose. Pharmacy speaks one language, medical billing speaks another. The crosswalk translates between the two. Let's start with a quick refresher. The National Drug Code, or NDC, identifies the exact product a pharmacy purchased and dispensed. It tells us the manufacturer, the package size, and the drug strength. The HCPCS code answers a different question. It tells the payer what drug is being billed and what billing units are being used for that drug. A big misconception about the crosswalk is that it's a simple one-to-one match. Sorry to break it to you, it isn't. A single HCPCS code can correspond to dozens of different NDCs, and a single NDC can have multiple HCPCS codes. Let's start with prednisone. HCPCS code J7512 links more than 210 different prednisone NDCs to HCPCS code J7512. Those NDCs represent different manufacturers, package sizes, yet are all billed under the same code. Enoxaparin is the same. HCPCS code J1650 links to 144 different enoxaparin NDCs. Now let's take a look at normal saline. Here's where things get interesting. All the different sizes of saline bags from different manufacturers and different sizes of bags can crosswalk into different HCPCS codes depending on how much was administered to the patient. If 250 milliliters is administered, it's J7050. If 500 milliliters is administered, it's J7040. And if 1,000 milliliters are administered, it is J7030. The NDC didn't change, the bag didn't change, the amount administered to the patient did, and so did the HCPCS code. Argatroban is another interesting one. The same exact NDC can crosswalk to different HCPCS codes depending on the patient's clinical indication. If argatroban is administered to a patient without end-stage renal disease, the claim bills as J0883. If the same exact vial is administered to a patient with end-stage renal disease undergoing dialysis, the claim bills as J0884. The last example we'll take a look at is buprenorphine injection. Bricadi has multiple NDCs, but the HCPCS code depends on the intended duration of therapy. Products used for 7 days or less, J0577. Products used for more than 7 days are J0578. Same drug, same NDC, depends on the intended duration of therapy. These examples show why the NDC-HCPCS crosswalk is so much more than a lookup table. The crosswalk doesn't simply connect one code to another. It also helps calculate the billing units. Let's take a look at another example. Keytruda, or pembrolizumab, bills under HCPCS code J9271. The descriptor is simple. 1 billing unit equals 1 milligram. If a patient received a 200 milligram dose, the claim reports a 200 billing unit. Now let's compare that to rituximab. J9312 represents 10 milligrams per billing unit. A 700 milligram dose becomes 70 billing units. That's why systems can't simply copy the dose into the claim. They have to translate the dose into the billing units defined by the HCPCS code. The crosswalk provides that translation. Unlike the original Rosetta Stone, this translator is constantly being updated. Every quarter, CMS publishes a new NDC-HCPCS Crosswalk alongside many other files. Why? The pharmaceutical market is constantly evolving. New drugs come to market. Some drugs get off the market. New biosimilars launch. Manufacturers discontinue products. Package sizes change, or even NDCs change. New HCPCS codes are created. Old HCPCS codes are retired. Every one of those changes can impact how a medication is billed. For pharmacy revenue cycle teams, these quarterly updates aren't just something that you read or an activity that you do once a year. Every quarter, the HCPCS Crosswalk must be reviewed, new HCPCS codes must be added to the CDM, and old ones must be taken off or archived. Just like learning a new word in another language, the translator has to keep up with the growing vocabulary. One major point I want to highlight is that CMS publishes what most organizations think of as the standardized NDC-HCPCS Crosswalk. For many commercial payers, they use that same reference. However, others may choose to build their own and implement updates on a different schedule. Most of the time, those differences are small, but sometimes they're not, and other times they could be completely contradicting one another. A hospital can submit a claim that is perfectly accurate according to the CMS Crosswalk and still receive an edit or denial from a payer that is using their own crosswalk. Thank you for listening to another episode of Revenue RX. If you enjoyed today's episode, please share it with a colleague and remember to like and subscribe. Healing patients is the mission, protecting the margin is the strategy. This is Revenue RX. A quick disclaimer, this podcast is for informational and educational purposes only. The views shared are my own and do not represent any organization that I am affiliated with. This is not legal, financial, or reimbursement advice, and you should consult your internal experts before making any decisions.